Good morning, everyone. I'm absolutely delighted to welcome you to the Sunday TEE breakfast session. As you are aware, we have been having this breakfast sessions on every Sunday without fail for over 1 year now. And today, Dr. Keshamurthy is available. Is Keshamurthy available in the group?
No,
I
sir.
see him here. Anyway, I'll take great pleasure to invite Dr. Nilesh Juvekar, who is one of the very prominent cardiac anesthesiologists of the country. He is a faculty for the National TEE workshop, the International and National TEE workshop, which we conduct in August. And he's very much experienced, and we would like him to begin his talk on diastolic dysfunction, which plays an important role in patients who have certain diseases. So I would like to request Dr. Nilesh to start the session, and at the end of the session, we'll have question answers. Please feel free to chat your questions and also comment if you would like to. Thank you so much. Dr. Nilesh Juvekar, please.
Sir, thank you for the kind introduction. First of all, good morning to all of you. So, we'll just start. Okay, so, this basically today's topic is perioperative diastolic dysfunction. As we all know, it is a very vast topic and so very difficult to cover in just 30 minutes. So, whatever I thought would be appropriate for this forum, I have just included in my talk. Okay, so basically diastolic dysfunction indicates impaired filling of the ventricles at low pressures and the abnormalities in the diastolic distensibility, filling or relaxation, which are usually associated with a lot of diseases like hypertension, diabetes, or in patients with coronary artery disease. A cross-sectional survey was done on 2,000 randomly selected sort of individuals from Minnesota who were aged around 45 years or older, and they found that the incidence of diastolic dysfunction is almost 5 times higher than that of systolic dysfunction, 28% versus 6%. Also, around 25% of the adults who are aged more than 40 years have got a diastolic dysfunction, and around 50% of the heart failures which are admitted to the sort of hospitals are diastolic heart failures who essentially have a normal ejection fraction. They are called as heart failure with sort of preserved ejection fraction. So diastolic dysfunction initially is compensated for by an increased left atrial pressure when the patient is essentially asymptomatic. And as the diastolic dysfunction progresses, these patients starts developing symptoms. So although both these terms are used interchangeably, they are not. They are two different pathophysiological conditions. Diastolic dysfunction is basically an echocardiographical terminology, while when these patients with these changes, when they develop clinical symptoms, it is called as diastolic heart failure. So what are these clinical symptoms? They may either have sort of orthopnea, effort dyspnea, or even pulmonary edema. When they are associated with either normal or mildly decreased ejection fraction and either echocardiographic or cardiac cath related changes, then it is termed as diastolic heart failure. Another parameter which is used for the diagnosis of heart failure are the biomarkers. So the BNP and NT-proBNP, they are specific markers in heart failure, and they are found to be higher in both the sort of heart failure with reduced ejection fraction as well as the heart failure with preserved ejection fraction. Obviously, with patient with reduced ejection fraction, their levels are higher. So the cutoff points are for BNP, it is 100 picogram per ml, and for pro-BNP, it is 300 picogram per ml. When these markers are elevated, they are independent predictors of adverse cardiovascular outcomes in these patients. So, just in short about the physiology of diastolic dysfunction, as we all know that it is divided into 4 phases. The isovolumic relaxation phase, which starts after the closure of the aortic valve and before the opening of the mitral valve. Then the sort of rapid filling phase, which amounts for around 70% of the LV filling. It is the initial phase, and it is seen as the E wave on our transmitral flow. Then comes the period of diastasis, in which not much flow occurs, and this particular period is inversely proportional to the patient's heart rate. And the last part of the diastole is the atrial contraction, in which around 30% of the LV filling occurs. This LV filling is basically a complex interplay which is regulated by the LA-LV pressure gradient and the LV sort of relaxation. In addition to the LV relaxation, there are certain extrinsic factors like the pericardial restraint or ventricular interdependence, and certain intrinsic factors like patients with increased myocardial stiffness or wall thickness, and these two parameters also have got a role to play in LV filling. Now coming to the pathophysiology. So as already said, the diastolic dysfunction is the inability of the cardiac muscle to relax properly and fill with blood during diastole. So it may be either because of impaired myocardial relaxation or because of increased cardiac muscle stiffness. In these sort of initial stages of diastolic dysfunction, impaired myocardial relaxation is the primary culprit, while as the disease progresses, the cardiac muscle starts becoming more and more stiff, and then a decreased LV compliance plays a major part. Myocardial relaxation is a ATP dependent active process which is regulated by the reuptake of cytoplasmic calcium into the sarcoplasmic reticulum. Low concentrations of calcium, which are seen in patients with ischemia, is associated with slow myocardial relaxation and hence increased diastolic dysfunction. Increased myocardial stiffness may be either secondary to myocardial hypertrophy as seen in severe hypertension or long-standing hypertension, aortic stenosis, HOCM, or in infiltrative disorders like amyloidosis, sarcoidosis, or patients who have a scarred myocardium like post-myocardial infarction, or in uncontrolled diabetics due to glycosylation of the cardiac muscles. Diastolic dysfunction is more commonly also seen along with systolic dysfunction. Now, what are the basic sequence of events? The initial myocardial relaxation and or decreased compliance, it leads to a delay in the ventricular filling, due to which the LVEDP increases, because of which the LAP increases, and due to back pressure, the pulmonary capillary pressure increases, leading to either pulmonary congestion or pulmonary edema. It is worth noting that this pulmonary edema is not due to poor LV pumping, but it is because of the inability of the left ventricle to accept blood from the left atrium. Now, in the preoperative evaluation, what are the various factors that an anesthesiologist should look for in order to say that the patient may have diastolic dysfunction? So, one is history of diastolic heart failure. Second is female more than 70 are more prone to have diastolic dysfunction. Patients with diabetes, hypertension, or chronic renal disease. Patient with recent weight gain, which may be because of sort of fluid overload, or patient may be obese. Similarly, patient might have ankle edema. Then patient with systemic hypertension and increased pulse pressure, that is more than 70 millimeters of mercury. Patient with jugular venous distension. On ECG, we should look for evidence of coronary artery disease, left ventricular hypertrophy, or atrial fibrillation. On echo, we should be looking for normal or slightly decreased ejection fraction, left atrial enlargement and left ventricular hypertrophy, raised biomarkers, and exercise intolerance. So these are the parameters in which, if present, then there will be a higher incidence of diastolic dysfunction or diastolic heart failure. So there is something called as rule of 70. It means that if the patient is aged more than 70 years, has a pulse rate of around 70, has a diastolic BP of more than 70, and a pulse pressure of less than 70, then these patients are more prone to have diastolic dysfunction. So now coming to the actual TE assessment of diastolic dysfunction. Before the advent of echocardiography, it was unknown why two patients having the same degree of systolic dysfunction behave differently. Means they have got different clinical manifestation, different clinical course, and different end result. So it was in those times a cardiac cath was done, and it was found that those patients who were hemodynamically more unstable had a higher incidence of having increased left ventricular end diastolic pressure. With the advent of echocardiography, it was found that these patients have an increased incidence of diastolic dysfunction. So the initial assessment of the diastolic dysfunction is done by transmitral flow and pulmonary venous Doppler examination with the help of a pulse wave Doppler, and the propagation velocity by M mode. Later, with the advent of the tissue Doppler, the diagnosis of diastolic dysfunction became better and more accurate. So, in the transmitral flow, it was first described by Kitawatake et al. In 1982, and they sort of described the transmitral flow spectral Doppler profile by putting the pulse wave Doppler at the mitral valve leaflet tips in the four chamber in the mid-esophageal four chamber view, and the parameters which were measured were the E wave velocity, the A wave velocity, the E by A ratio, the deceleration time, and the A wave duration. Okay, so as the diastolic dysfunction progresses, it gives rise to different spectral Doppler profile, according to which the patient is graded as grade 1 to 3 or impaired relaxation, pseudonormal or restrictive pattern, which we'll be seeing later. Now, the pulmonary venous Doppler is obtained by placing the pulse wave Doppler around 5 to 10 millimeter inside the left upper pulmonary vein, and with that the spectral Doppler profile which is obtained has got the S wave, the D wave, which are the diastolic waves, and the AR wave. So the S is again divided as S1 and S2. Basically, the sort of S1 wave is because of the atrial relaxation. The sort of S2 is because of the mitral annular descent. The D wave is because of the antegrade diastolic flow. And the AR wave is because of the back pressure into the pulmonary vein when the atrium contracts. So as the left atrial pressure increases, the AR duration will go on increasing. Now, coming to the mitral inflow propagation velocity, it is obtained by placing a color flow Doppler across the mitral valve in the four chamber view, and the M mode is passed through the center of this particular color Doppler in order to get this particular profile. Okay, so as the blood flows across the mitral valve towards the LV apex, the sort of slope of this particular aliasing velocity, that is the outermost velocity, that gives us the propagation velocity, and impaired relaxation will slow the propagation of blood and thereby reduce this slope. So any VP which is less than 50 centimeter per second is consistent with impaired relaxation. Again, the propagation velocity is more valid assessment of the LV relaxation property compared to the transmitral flow, because the transmitral flow measures a point measurement at the tip of the mitral valve leaflets. Now coming to tissue Doppler imaging. So as there were advancements in the echocardiography, it was feasible to sort of measure higher frequency, low velocity signals, and hence the tissue sort of velocity measurement became possible. Okay, so in the tissue Doppler imaging, we place the sample volume, that is the pulse wave Doppler, is placed 1 centimeter inside the lateral and the septal mitral valve annulus to obtain a particular pulse wave Doppler spectral profile. So as the LV sort of fills up and it sort of dilates, there is a brisk movement of the mitral annulus, and this is represented as the E prime. Okay, so this is the E prime, and as the atrium contracts, it gives us the A prime. Okay, so a typical TDI signal, that is the Doppler signal, has the E prime, A prime, and the S prime. Okay, so it is important to note that when we sort of acquire these particular images, the sort of velocity scale should be set at less than 20 centimeter per second, and the acquisition should be done at least 3 consecutive cycles and done at end expiration. And the sort of sweep speed should be between 50 to 100 centimeter per second. This E prime is basically may be influenced by preload in a normal heart, but as the diastolic dysfunction develops, it becomes preload independent, and therefore E prime is more of importance as compared to the E wave. Now, the value of E prime is higher at the lateral annulus as compared to the septal annulus. Why is that so? Because the lateral annulus is more free than the septal annulus due to the sort of surrounding structures. In case of intraoperative key, aligning the Doppler for at the lateral mitral annulus is easier, and in case of TTE, that is the transthoracic echo, aligning it with the septal annulus is easier. So the measurements of E prime, they actually represent the early diastolic active relaxation, but they do not represent the LV compliance. So then what is the parameter which is used for LV compliance? It is E by E dash ratio. And if it is less than 8, it is considered to be normal. If E by E prime is more than 15, then it represents increased mean atrial pressure. And if it is between 8 to 15, then other Doppler variables should be used in order to grade the diastolic dysfunction. Now, E by E prime is considered fairly accurate and relatively independent of the LV systolic function, various rhythm abnormalities, LV hypertrophy, and mitral regurgitation. E prime and A prime are more unidirectional with the development of diastolic dysfunction as compared to the E wave, in which, in case of pseudonormal, the sort of E wave again sort of increases. A prime is an excellent marker of the global atrial contraction and it is independent of the flow of blood filling the LV. The A prime does not become smaller but rather increases with the progression of diastolic dysfunction because of more vigorous contraction of the left atrium. In diastolic dysfunction, the E prime predominantly decreases with the progression of diastolic dysfunction, and hence the E prime by A prime ratio decreases from more than 1 to less than 1. Okay, now another parameter which we should be looking at is the A wave duration. This is the transmitral flow, and this is the pulmonary venous Doppler. So this is the A wave, which actually represents antegrade flow, and this is the AR wave, which actually represents the sort of retrograde flow. So normally the A wave duration should be more than the AR duration, but if the AR duration is more than the A wave duration, that is the retrograde flow is more than the antegrade flow by more than 30 milliseconds, then it is considered to be a good parameter of diastolic dysfunction. Another parameter which we can look at is the E by VP ratio, and it correlates well with the left atrial pressure. If this ratio is greater than or equal to 2.5, then it predicts a PCWP of more than 15 millimeter mercury with reasonable accuracy in patients with depressed ejection fraction. Now, another parameter which we will be looking at is the isovolumic relaxation time, which is basically the time from the closure of the aortic valve to the opening of the mitral valve. Now, this IVRT is obtained by placing the pulse wave Doppler in the 5-chamber view or on transthoracic or in the deep transgastric view. It is placed over here so that we have to get the LVOT profile as well as the mitral valve profile. So the time from the closure of the aortic valve, that is the end of this particular systole, to the opening of the mitral valve is the IVRT. Normal IVRT is around 70 to 90 milliseconds, but when it is at its extreme, that is less than 60 being called as short IVRT and more than 110 being called as long IVRT, then only it has got some sort of value. Okay, so a prolonged IVRT denotes diastolic dysfunction. However, though it is a direct measure of LV relaxation, it has got limited accuracy and clinical application, mainly because it varies with age, being sort of shorter in younger individuals, and it prolongs with age. Also, as the diastolic dysfunction increases and the patient develops pseudonormal pattern, because of the increase in the left atrial pressure, the mitral valve opens early and therefore the IVRT gets shortened. So, though the diastolic dysfunction increases, the IVRT decreases. Okay, so that is why it is not a very reliable parameter and should never be used in isolation. Compared to the IVRT, the flow propagation velocity is a more reliable indicator of LV relaxation. Now, initially when there is no diastolic dysfunction, there is a free flow of blood from the left atrium to the left ventricle with a very minimal LA-LV gradient. But as the diastolic dysfunction goes on increasing, okay, the sort of LV becomes more stiff. That is the time when the LA-LV gradient decreases, as a result of which the E wave velocity decreases and the E becomes less than the A. Excuse me. So the E by A ratio, which is normally more than 1, becomes less than 0.8. Associated with that, the deceleration time, that this slope, the deceleration time increases to more than 200 milliseconds. And here the AR duration is still more than the A wave duration. As the diastolic dysfunction increases, this deceleration time slowly goes on decreasing. Okay, if we see the pulmonary venous Doppler in grade 1, that is impaired relaxation, the sort of systolic wave is more prominent, is more sort of predominant, and so S by D ratio is more than 1. And as we say that, and as we said that the E prime has got a is always unidirectional. Hence, with the decrease in E wave, the E prime also decreases. Hello? Yeah. The sort of E prime also decreases, and the E by E prime ratio is less than or equal to 8. Okay, so these are the various parameters of grade 1 diastolic dysfunction. Now, as the diastolic dysfunction progresses, the as a compensatory sort of mechanism, the LA pressure goes on increasing in order to sort of maintain the LA-LV gradient to ensure adequate LV sort of filling. And so again, the sort of E wave becomes more than the A wave, and and in these cases, the E by A ratio is between 0.8 to 2. As I said that with increase in the grades of diastolic dysfunction, the deceleration time goes on decreasing, and so the deceleration time here is around 160 to 200 milliseconds. However, now the AR duration becomes more than the A wave duration by more than or equal to 30 more than or equal to 30 milliseconds. Now, as the LA pressure increases, there is impediment for the flow to come from the pulmonary veins into the LA, resulting in which the S wave gets blunted. So as a result of which now the SD ratio becomes less than 1, and again the E prime is less than the though the here the sort of E wave increases, the sort of E prime continues to be lower, and the E by E prime ratio here is around 9 to 13. As the diastolic dysfunction further worsens, the LV becomes more stiff, as a result of which, even with a very small blood flow from the LA to LV, the LVEDP suddenly rises. And because of this rise in the LVEDP, the further atrial contraction is sort of cannot have the expected amount of sort of contribution to the LV filling, due to which the E is very large as compared to the A wave, and hence the E by A ratio is more than 2. So it is very easy to diagnose grade 3 diastolic dysfunction, in that if E by A ratio is more than 2, you can say that it is restrictive pattern of diastolic dysfunction. In this, there is a further decrease in the deceleration time to less than 160 milliseconds, and again the AR duration is more than the A wave duration. Now here there is a marked decrease in the S wave compared to the D wave in the pulmonary venous Doppler, and here the E by E prime ratio is greater than or equal to 14. Okay, so this is a cartoon which will show the various changes which are associated with the diastolic dysfunction. Why I have added this is because this shows, if you concentrate over here, it says that the sort of stage 3 is divided into two types. One is stage 3 reversible restrictive, and sort of stage 3 fixed restrictive. Why is this so? This is based on the what is the sort of response of the patient to the Valsalva maneuver. So if with the Valsalva maneuver, if the grade of the diastolic dysfunction, if it decreases from grade 3 to grade 2, then we can say that it is grade 3 sort of reversible restrictive pattern. And if it does not, then obviously it is grade 3 fixed restrictive pattern. I could not get an image for the grade 3, but here if you see, this is a pre-Valsalva pseudo-normal pattern, which after giving the sort of Valsalva maneuver has changed into the impaired relaxation time. Okay. So as we know that transmitral flow has its own limitations, and hence in 2016, the American Society of Echocardiography and the European Association of Cardiovascular Imaging, they found out newer guidelines in which they focused more on increased left atrial pressure rather than grading the diastolic dysfunction. So they included four parameters, mainly the average E by E prime, means which is the mean of both the septal as well as the lateral E by E prime, which should be more than 14. Which if more than 14, number one. If the lateral E prime is less than 10 centimeter per second and septal E prime less than 7 centimeter per second, the TR jet velocity more than 2.8 meter per second, and the LA volume index, which normally is around 16 to 28 ml per meter square, if it is more than 34 ml per meter square. So they have included these four parameters in order to grade the diastolic dysfunction. So in patients with normal EF, if more than half of these, that is, if 3 or 4 are positive, then it is said, then the patient is said to have diastolic dysfunction. On the contrary, if the patient has got a decreased ejection fraction, or if he has a normal ejection fraction with myocardial disease, then it is again graded as grade 1, 2, and 3. In grade 1, basically the the E by A ratio will be less than 0.8, and more than half of this criteria will be sort of negative. While in case of grade 2, more than half of the criteria will be positive, while in grade 3, the E by A ratio will be more than 2. Okay, so this is a very crowded slide, but why I put it, because these four parameters are not without its own fallacies. So when we take the TR jet, so if we cannot get a good TR jet envelope, or if TR is not present, then this particular parameter cannot be obtained. To get the LA sort of volume index, it is easily obtained on a transthoracic echo, but getting a full LA in a transesophageal echo is a bit difficult. Also, LA dilatation is seen in other conditions like high output states, bradycardia, heart transplant, atrial flutter fibrillation, significant mitral valve disease, so on and so forth. So also the E prime has a limited accuracy in patients with coronary artery disease and patients with regional wall motion abnormalities. If the patient has got a significant mitral annular calcification in the presence of surgical rings or prosthetic mitral valves, and also their sort of cutoffs are dependent on the sampling site as well as the age of the patient. And as far as the E by E prime ratio goes, again they are not accurate in sort of normal patient, in normal subjects, in patients with mitral annular calcification, and also in patients with coronary artery disease and regional wall motion abnormalities. Okay, so this is the sort of flow chart from these guidelines, which shows how the patients are graded into grade 1, 2, and 3. Now, what is worth noting is that if only two parameters are available and only one is positive, then the LV grade, the left ventricular diastolic dysfunction grade, it remains indeterminate. Okay. So just to see what are the factors which should be considering before interpreting all these variables, is that the presence of chronic AF causing LA enlargement, age influencing E wave cutoff values, the presence of tachycardia, the use of vasopressors and inotropes, the presence of mechanical ventilation, especially with PEEP, which will decrease the E prime cutoff values, the presence of mitral and aortic valve disease, the sort of fluid status of the patient, especially patients who are dehydrated, maybe either because of the nil-by-mouth status or maybe because of increased blood loss during surgery, or getting a full LA to calculate the LA volume. And it is important to note that the TDI values are not validated with the transesophageal ECMO. So what is the impact of diastolic dysfunction in the perioperative settings? Okay, so it is a well-known fact that in patients undergoing cardiac surgery, diastolic dysfunction, especially the advanced stages, it correlates well with difficult to wean from CPB and the need for higher inotropic support and use of mechanical circulatory devices. We all must have seen that if while doing an off-pump surgery, if the patient crashes on pump, then when we try to come off pump, if we do the echo of this patient and diastolic function, invariably these patients have got grade 3 diastolic dysfunction, and hence they need inotropic support as well as IBP to come off. Okay, there is some correlation between advanced diastolic heart failure and postoperative atrial fibrillation. Also, in patients undergoing major vascular surgery, preoperative diastolic dysfunction is more frequent as compared to isolated LV systolic dysfunction. and it is a more important predictor of postoperative heart failure as well as prolonged hospital stay as well as adverse cardiovascular outcomes. Also, the long-term cardiovascular mortality is more in these patients compared to those who do not have diastolic dysfunction. Okay. Now, when the patient is on mechanical ventilation, okay, and the LV preload and afterload they are decreased. And when there is a transition, when we take these patients onto so spontaneous ventilation, then it always creates an unfavorable LV loading conditions. And presence of advanced stages of diastolic dysfunction are strongly associated with weaning failure from mechanical ventilation. There are various studies which have found this. Some studies have found that only lateral E by E prime is the only factor independently associated with weaning failure, while another study showed that patient with weaning failure had a low E prime, and when these patients were successfully weaned, their E prime velocity had already increased. Now, how do we sort of manage these patients? Basically, there is no magic bullet that will rapidly improve LV diastolic dysfunction. There is no sort of study that demonstrates that improving diastolic dysfunction in critically ill patient could beneficially impact the prognosis. There are certain drugs like beta blockers and ACE inhibitors which have a positive effect on diastolic dysfunction. However, they are more for long term than for the perioperative period. And amongst the inotropes, as compared to the inotrope, the sort of sympathomimetic inotrope, which actually increase the diastolic dysfunction, or the phosphodiesterase 3 inhibitors like milrinone, which have no much effect on the diastolic dysfunction. Levosimendan has been found to have a beneficial effect in improving the diastolic dysfunction. So, grade 1 diastolic dysfunction is easy to manage, and maintenance of sinus rhythm is crucial. In grade 2 diastolic dysfunction, the sort of fluid balance is critical because hypervolemia can cause pulmonary edema, and hypovolemia can decrease the compensatory mechanism to maintain the LALV gradient. And in grade 3 diastolic dysfunction, the cornerstone of management is maintaining good loading conditions, maintaining a sinus rhythm, and avoiding myocardial ischemia. So this is the slide which shows the various management sort of strategies for managing a patient with left ventricular diastolic dysfunction. Okay, so as we had seen that those who have got who have been labeled as either indeterminate type of diastolic dysfunction. So in these particular patients, the evaluation of the strain and strain rate by sort of speckle tracking can be a very sort of useful in classification of diastolic dysfunction, and there have been increasing number of studies which corroborate the sort of usefulness of the cardiac strain, especially the diastolic strain rate in identification of these diastolic dysfunctions, and the LA longitudinal strain has been intensively studied. However, still there is no sufficient evidence for the routine use of this strain and strain rate for the diagnosis of diastolic dysfunction. Okay. So by now, I think everybody must be like this. If there are any questions, I'll be more than happy to answer. Thank you very much.
Dr. Keshavamurthy, can you please conduct the meeting?
Thank you, Dr. Nilesh, for that excellent presentation. Sorry, Rajiv did not let me in immediately, so I was late for the start of the program. Very nice presentation, and very important, as you said, in the immediate post CABG situation, and I feel even aortic valve replacements in aortic stenosis, where we find that we are finding it difficult to come off bypass. So when these parameters have to be considered to change the inotrope or change the strategy to make sure that the patient comes out of bypass. There is one question by Dr. Kedar: how to calculate LA volume index?
Yeah, so basically we should get the full LA in which it is made from the mitral annulus and the pulmonary veins, they are sort of excluded. So once we get the LA area, then it is indexed to the patient's body surface area.
Okay. I think Kedar got the answer.
Hello.
Inamdar, yes, madam.
Can I add to this? Nilesh, very good presentation, very
Thank you,
nice,
madam.
crisp, and I enjoyed it. I updated myself and really enjoyed. See, calculation of LA volume, there is a formula, at least in transthoracic echo, that is area 1, that is in 4 chamber, okay, excluding pulmonary veins, area 2 in 2 chamber, and then you multiply A1 into A2 into 0.851 or something like that, divided by the shortest length of LA. This gives you LA volume, and then you divide this by body surface area. It is automated. Some machines give it on its own, but that is how LA volume is calculated.
So how about by Simpson, by using the Simpson formula? That I think that is easy compared to other big dimension cannot be made in the.
You're not
Can
audible.
you hear me, sir?
Yeah, his question is, can't we use the Simpsons method
Yes.
to find the
As
LA volume and divide by the body surface area so that you get the LA index?
yes, so as madam said that in these are machines only, they always give it, and it is done in the like in the Simpson method in the 4 chamber and the 2 chamber view.
See, I tried with Simpson, but somehow this area in 4 chamber and area in 2 chamber gives better results, because you have to, you see LA volume over there, you see LA size, you know, eyeballing. So this gives better. Somehow I'm not comfortable with Simpson for LA. LV, of course, Simpson is best.
Actually, in trans esophageal echo, it is very difficult to get the entire LA in order to calculate this.
Yes, and again the other situations like TR with a right ventricle dilated, or you have a large L left ventricle for AR, the LA size becomes very difficult to be assessed completely in this.
Yeah.
Sir, in assessing the diastolic dysfunction with restrictive and constructive pericarditis,
Yeah.
how are you going to? What are the parameters you take, sir?
Yeah. In case of restrictive, the E prime is grossly decreased. Okay, it is usually less than 4 or 5 centimeter per second, and the E by E and the obviously the E by E prime is more than 15, and the E by A ratio is more than 2, and it is more in case of restrictive as compared to constrictive.
Okay.
Can I add, Dr. Keshav?
Yes, madam, please.
Yes, ma'am, please.
This in constrictive, there is this annulus reversal, that is usually the lateral annulus is more than the medial, but in constrictive pericarditis it is the reverse, because obviously the lateral wall is constricted by the pericardium, hard pericardium. So that is one of the important signs to differentiate. And as Nilesh said, remember this, that restrictive is a myocardial pathology, and constrictive is the external coating which is preventing the heart to expand, and there is a restriction. So all these myocardial pathologies will show less TDI, low ejection fraction, and that is why, as Nilesh said, that there is this TDI is less in restrictive as compared to constrictive.
Thank you, madam. Sir, you said
Yes,
that
sir.
velocity propagation velocity is more than 55. It's so for everything, or in case of especially papillary rupture or tethering of this one, whether
No,
this
if it is tethering, then I don't think that this holds true. In case of papillary muscle rupture and all, I don't think that propagation velocity will hold true. There should not be any myocardial there should not be any mitral valve pathology.
Okay.
For any of these to be held true.
Okay. Thank you, sir.
Any
Dr. Ratan Gupta is available.
Good morning, sir.
Yeah.
I think this is an excellent presentation. You covered all aspects, Dr. Juvekar. In the intensive care, we do have trouble with the patients who have impaired LV function. It's very obvious. But in case patients have preserved systolic LV function and who are giving trouble, especially arrhythmias and the heart rate going up, patients on stiff inotropic support, I think coming down on the inotropes and keeping them on beta blockers and in case the renal function is okay, keeping them on ARBs helps. And other thing which we do monitor in the intensive care in adult side is keeping a check on the weight, making sure that they are not gained fluid overload. Using diuretics is another thing. And recently we have tried extubating these patients and putting them straight away on NIV to make sure that they don't go hypoxic, which can cause rhythm issues with these patients as well. So that is working well for us. Keeping a check on the weight and using beta blockers early really helps in these patients.
Yeah, there are a lot of trials like the emperor reduced, emperor preserved, which see for the efficacy of drugs like empagliflozin and all these things, but they are all for long-term management. In the perioperative or in the ICU, as you said, sort of avoiding fluid overload, keeping them in sinus rhythm, and inotrope, if at all, those with negative lucidotropy effects like sort of levosimendan, these only would be the cornerstone of the management of patients with diastolic heart failures.
Yeah, we have been using levosimendan in these patients of late. I have not particularly noticed any advantage when compared to the dobutamine, milrinone, and levosimendan, but we have started using levosimendan of late. So let us keep a watch on that.
Yeah, basically the advantage of levosimendan over dobutamine is that it does not cause tachycardia, because tachycardia is going to worsen the diastolic dysfunction. So levosimendan, if the patient's renal function is okay, possibly would be a better choice compared to dobutamine. And it has been shown that the milrinone does not alter patient diastolic dysfunction. It has got more effect on the LV function as compared to the diastolic dysfunction. That is what actually I found in the literature.
Yeah. And I think we also use atrial pacing to keep the heart rate on the higher side in postoperative patients. We just want to make sure that the cardiac output is maintained. Probably, I think we should be very careful because we might be causing, with increased heart rate, we might be leading to diastolic dysfunction. I think that needs to be kept in mind.
Yes.
Doctor, can I add something to this?
Please, ma'am.
Madam.
See, regarding this tachycardia and use of beta blockers, if he is in grade 1 and 2, one can use beta blockers. There is no problem. I think it will improve the diastolic dysfunction and it will improve the forward flow. But if patient is in grade 3 and already having tachycardia, on which his cardiac output is dependent, and if you give beta blockers to this patient, certainly it will worsen the situation. So in which grade he is for starting beta blocker, whether he is in grade 1, 2 or 3, because in the grade 3 already most of LA is emptied into the left ventricle in the E wave only, that is initial part of the diastole. There is hardly, because of severe rise in LAP. So everything goes into the ventricle in the initial part of diastole because of increased LAP. So atria has nothing, blood remain to contract, and that is why A wave is very small. So in this case, by reducing heart rate, we are not achieving increased forward flow or anything like that, because already everything is gone. And in addition to that, tachycardia will maintain his cardiac output. If this patient, if you give beta blocker, that will be disastrous.
No, madam, I don't think so that this is the case, because basically these patients, if they are heart failure with preserved ejection fraction, they will most probably sort of present to us with hypertensive failures. And it is not the increased E wave or the decreased A wave is basically because the LV has become so stiff that even with a sort of small volume of blood which comes from the LA into the LV, the LVDP suddenly rises. And because of this high LVDP, the atria cannot contract in order to deliver the further filling. Therefore, the LV filling is sort of hampered. So, if we can decrease the heart rate, it is always beneficial in these patients, provided the patient's systolic function is normal and the patient has got a normal blood pressure. That is what is my take on it.
Sir,
So,
Let's
Muralidhar
discuss
sir,
this sometimes.
anyone?
Yeah. In essence, if you want to manage patients with diastolic dysfunction, to some extent, you just think of a situation like aortic stenosis. The patient has stiff ventricle and not relaxing the ventricle. So, physiologically speaking, whatever parameters you apply for aortic stenosis, you apply the same thing here, it should work. You have to maintain the heart rate between 60 to 80 or 60 to 90 at the most. Maintain normal sinus rhythm, atrial contribution to left ventricular filling must be maintained. Maintain afterload, do not increase it, but maintain the afterload and preload and avoid arrhythmia. These are some of the fundamental principles needed for aortic stenosis. Same thing can be applied to patients with diastolic dysfunction.
But fluids cannot be accepted also.
Which one?
Fluid can't be overload.
No, you have to be cautious. You have to be extremely cautious. What is okay for normal left ventricle? For example, 200 ml is okay for left ventricle, but a patient who is on diastolic dysfunction, you have to have a mechanism to monitor the left atrial pressure and give the fluid. Because their LVDP is already high, so even 200 ml may push them into pulmonary mass. So you need to have a mechanism to monitor the left atrial pressure, especially in major high risk surgery. That is one. And the other thing I want to say, if you're talking about restrictive physiology, there the patient is already gone to a stage where the prognosis is very bad, and I'm sure that such patients do have coexisting systolic dysfunction. And there, Dr. Sanjeevani mentioned about control of heart rate may not, may actually worsen the condition, but you have to take a call on that. You have to monitor all the other parameters, have a measurement of the vascular resistances, cardiac index, and the filling pressures, and then titrate the drugs in such a manner that the cardiac index is maintained and the tissue perfusion is maintained.
Sir, he mentioned E prime and all in severe less than 7, 8 lateral E prime. How do account this one in patient with the transplanted heart, sir? See, transplanted heart, in fact, if you see what is the
Can
value?
anyone answer?
Early...
I have no experience with heart transplant. I'm sorry. So,
because
if anyone can elaborate,
because early rejection can be suspected if they mention it, sir. That's why I'm telling you. E by E prime. If it is 2 to 3, you can, without any other signs, we can suspect that the transplantation is be going to reject. It's early sign.
E by E prime ratio,
yes.
you're talking about ratio?
Yes, sir.
No, that ratio has to increase. If it is 2 to 3 means it is only E prime value that he is talking of.
Yes.
E by E prime, if it is more than 14, indicates a
very bad.
Okay. So E by E prime is a measure of filling pressure, indirect measurement of filling pressure. So it cannot be 2.
No, sir, he's talking about E prime value. which normally has, if it is less than
Yes.
10 at lateral annulus, it is
Should
considered
be
as
more
diastolic
than 12,
dysfunction.
sir. Should be more than 12 or 14 normally. So
As
early
long as
sign.
it's 10 and above, it's fine. Even 7 and above is fine. 7 is
fine.
depressed myocardial contractility, but you
Because
can improve the contractility with inotrops and things like that. But 2 is very bottom, rock bottom.
yes, 2 to 4 means we can suspect directly 100%. There will be rejection. And it's mentioned
2 is very
offer.
Sir, can I add, sir?
Yes.
In the post-transplant patients, we notice that there will be some amount of RV dysfunction in the initial stages. Many times over the week, it gets better. That might be the reason why the septal E prime might be on the lower side in immediate post-transplant patients. I'm not sure about
Could
the
be
reason,
one of the
but
reasons.
we do see RV dysfunction.
Yes. You are right. RV dysfunction occurs in as much as 10% of the patients who undergo heart transplantation, and 30% in patients who have LVAD implantation, and about 5% in congenital heart disease, about 1 to 2% in coronary artery bypass. The problem with right heart dysfunction is that if the strategies to treat RV dysfunction are not well understood as compared to left ventricle, and right ventricular failure post-operatively associated with a mortality of 30 to 40%.
Okay.
There is high mortality.
Sir, good morning.
Yes.
Sir, how the RV dysfunction in the post-op period in a transplanted heart, how it is going to reduce the lateral E prime? I mean the reduction of lateral E prime, is it related to the RV dysfunction or it is purely because of post-op diastolic dysfunction?
Dr. Ratan, can you take that question? After that, if I can add something.
No. What I was trying to mention is the septal E prime. I was not talking about the lateral E prime.
Usually we go by
the septal function goes
right
down
ventricle.
actually. Yeah.
We do go by
Okay.
for right ventricle. For the right ventricle, you have to go for right ventricular fractional area change, then TAPSE and the tissue Doppler of the right ventricle. Right ventricular free volume.
Again, how?
Yes. Right ventricle is S prime on annulus of the tricuspid wall, laterally placed. Yes, and it should be around 10. 10 is the cutoff point. And of course, TAPSE and other things.
Fractional area change also is mentioned, and
fractional area change, yes.
And to be really accurate, you have to go by 3D estimation of the RV ejection fraction.
Yes. Can I add something to preoperative evaluation, Dr.
Keshamurthy?
Yes, madam.
See, this Nilesh has very elaborately explained all the pre-op conditions, except one which is very important, that is history of snoring. If patient is snoring and he doesn't have blood pressure or anything, he is very good correlation between snoring and diastolic dysfunction. That is number one. And we can ask these very simple questions. Ask his wife whether he is snoring. Another important thing is that patient may not have anything because it is a microvascular systemic disease. Now it is considered as a systemic disease and it is a microvascular, more common in women. So patient may not have anything preoperatively, but patient may be having diastolic dysfunction. There may not be concentric LVH or all those things. And of course, diastology studies are done properly in preoperative period, then yes, we can find out. But otherwise, take this patient, elderly female, with a pinch of salt. If anything is not mentioned preoperatively, she may be having diastolic dysfunction. So that is
do you think that
surprises.
ladies should have echocardiography preoperatively, irrespective of the surgical procedure.
Sorry, I didn't get it.
Do you think, do you recommend that all elderly ladies should have echocardiography to detect diastolic dysfunction before surgery,
Yes,
irrespective
yes,
of the
yes,
surgery?
yes. Even for a minor surgery, yes. Because echo is
No,
all painless and not invasive, not very costly also. And why not? In 2022, I think one has to do echo before. That's a. I had done echo 30 years back before tonsillectomy of my daughter.
Huh.
So it was just a tonsillectomy, but I said I want her echo to be done. So these are very basic things. I think echo is a very basic thing. There should not be any discussion on it actually.
No, no, this is your personal opinion. Are there any guidelines for
no, no, no.
No,
There are no
no
guidelines.
guidelines.
If the patient is not symptomatic, then there are no guidelines. Because all the guidelines comes from the West, where it is very expensive. Here it might be cheap, but
No, but
from
in West they always do echo as a
no,
primary
no.
thing.
No, madam, never, never. They have got very strict guidelines as to who should undergo an echocardiography. You don't even get an appointment over there for an echocardiography for 2 weeks.
Okay.
So,
that is true.
so
That is
But
true.
I
But
think
I like to
fetal
say,
Probably
echo is done very,
as the in an asymptomatic patient, we tell echo, the surgeon may become agitated, so it will be very difficult to
no,
go and get.
we don't make out what you are saying, Keshav.
Hello,
There is some disturbance. We can't make out what you're saying.
hello.
Not hearing properly, sir.
Exactly, not able to hear.
Hello.
so you are muted, Dr. Keshav. You are muted.
Somebody's microphone is on, I think.
Somebody's microphone is making a lot of noise. No, I said
Yeah.
the moment we say for an asymptomatic patient to get one echocardiography done, immediately the surgeon becomes very apprehensive and jittery that we may have to send him for an echocardiography before the patient. That if there are no more questions, shall we conclude this session, sir?
No. I would like to make one comment. I think the Western guidelines and our situation is somewhat different. See here, Asians are vulnerable to heart disease much more than the Western population. That's the bottom line. And if the patient is more than 65, even if he or she is not asymptomatic, I would like to get the echo done because the simple reason that the coronary artery disease, we are more vulnerable to coronary artery disease and heart disease as such. And a patient may have asymptomatic diastolic dysfunction or asymptomatic LV, EF may be reduced. We do not know. So I would like to do the echocardiography if the patient is more than 65, even if it is asymptomatic from cardiac point of view. That is my impression on that.
Dr. Muralidhar, can I add one small thing to this?
Yeah, with permission of Keshav Murthy.
Keshav, Dr. Keshav.
Yes, madam.
See, if patient is complaining of breathlessness and everything is normal on echo, echo is done with complaints of breathlessness, then many times they do diastolic stress echo to reveal the diastolic dysfunction, because sometimes at rest they are absolutely asymptomatic, but when under exercise they do have rise in pulmonary hypertension and all, they show all signs of your E and A and E prime, all those things. So that is another addition to preoperative assessment.
Thank you, madam.
But there the patient
Hello.
is symptomatic. No?
Symptomatic, yes.
So you are justified in doing that. But otherwise also, if the patient is greater than 65, I think that I would like to do it. we have to have our own guidelines to see
Yes.
what we should follow.
Our ischemic heart disease pattern in India is very diffuse, not discrete, and the vessels are very thin compared to Western. They have 3-4 millimeter size of coronary, where we have one, sometimes one shunt of one we had to put it inside. So naturally, this is a difficult scenario, as Dr. Murlidhar says. Asian is a different population, difficult ischemic heart pattern.
Thank you, Sanjeev.
Okay.
Anybody else?
Anyway.
Hello.
Yes,
Hello.
yes.
Sir, Dr. Juvekar, excellent presentation. Vaishali here.
Yes.
Yeah.
Please,
I just want to ask you. You said in your slides that it is more common in ladies. Is there any particular reason? This is the first question.
No. There is no particular reason. In fact, what now, if we say contrasting to what the madam said, that the people who snore more, they have got more incidence of diastolic dysfunction. Ladies usually don't snore as much as men, but still they have got an increased incidence of diastolic dysfunction. So there is no particular this is reason.
Okay. And secondly, in West, as you said, they don't do echo for if patient is not symptomatic, no echo. And if you want to do instead of normal echo, we should do dobutamine stress echo, so that we know that patient is undergoing surgery, he is stressed out, he may be stressed out. So more than a simple echo, dobutamine stress echo would be better. What do you think?
No, nowadays, with the advent of nuclear medicine, people are going more in for sort of adenosine stress MPI rather than dobutamine stress echo. It is not a very easy thing to do. Number one. Number two, it takes a lot of time. So in our setup, one dobutamine stress echo takes 1 hour. So so it is usually done after 3 o'clock. And so, and with the advent of sort of your adenosine stress MPI, nowadays nobody is going in for a dobutamine stress echo. It will be easier to go in for nuclear medicine.
Then why don't we go for adenosine only instead of simple echo in symptomatic patients?
No, but why go in for an sort of advanced test when we can get a diagnosis by a simple test? Yeah, so ultimately, 2,000 rupees and 10,000 rupees, something has to be justified, no? But in our hospital, patients of TKR who have got risk factors, they undergo either a dobutamine stress echo or an sort of adenosine MPI because they cannot walk on the treadmill.
Correct. Okay, fine. Okay. Thank you.
Variably, they might not be able to work on the treadmill because
yes.
Because of TKR. That's why they all undergo pharmacological stress testing.
Yeah, there's a stress test difficult in those cases. Okay.
No, that is what that was my same question. Like symptomatic patients, elderly patients who cannot
walk
or anything, they should go out. Yeah, correct. Thank you.
Ideally, to do stress nuclear scan so that you get all the details before you subject them for the surgery. If there are no more questions, shall we conclude? Very nice presentation, Dr. Nilesh. Thank you.
Thank you.
Very nice discussion. We had all stalwarts discussing about the various aspects and highlight so many things which we routinely have to do it. And that's what I keep always thinking, that if we have a free probe and a machine, that every CABG patient should have a echo done at the end of before grafting and after grafting, just to find out what difference we have made by the whole procedure over the day. And most of it is again detected quite a little later in the post-op also. So we have to watch out for the implications and the uses of these things in the perioperative period. Thank you all for the wonderful discussion. Thank you, sir, Dr. Murlidhar, sir. Thank you, Dr. Nilesh.
Yeah, thank you.
Thank
Have a great Sunday.
Thank you, Keshav. Thank you, Nilesh, for that excellent presentation, and thank you everybody who all participated and
Thank you,
part of this meeting. Thank you so much.
Prabhu sir. Thank you.
Rajiv also. Thank you.
Rajiv for making it live for all. Thank you.
Yes, yes, yes. Thank you. Thank you.
Thank
Thank you,
you.
sir.